Hello, welcome to RAAONLINE. I am Dr. Vijay Raghavan. Now the topic is multinodular goitre. The basic pathology is there is a diffuse enlargement of the thyroid gland followed by a differential regression of some areas of the gland while other areas continue to hypertrophy. Why this differential regression is not finally settled? Various theories, various propositions proposed, but final word is not yet said. Now the hypertrophied areas coalesce to become cystic nodules containing no iodine. These nodules are non-functional and the functional areas are in between the nodules or internodule areas. The most important thing to remember is female sex seem to be the most important factor in the pathophysiology of multinodular goitre. Now the primary factors in pathophysiology of multinodular goitre is functional heterogeneity of normal follicular cell, maybe due to genetics, maybe due to environmental factor. As we said, final word is not yet out. Now gender, women is an important factor. Subsequent functional and structural abnormality leads to growing of goitres. Secondary factors are elevated TSH, iodine deficiency, natural goitrogens, inborn errors of thyroid hormone synthesis, smoking, stress, certain drugs, other thyroid stimulating factors like insulin-like growth factor 1 and epidermal growth factor. These are also possible responsible for multinodular goitre development. As we said again, it is endogenous factor which is a gender. Clinical features are most commonly seen in women. They are completely asymptomatic and often euthyroid, presenting for cosmetic reasons. Very unusually you see pressure symptoms on the trachea, esophagus or recurrent laryngeal nerve only if the goitre is very large. Other possible presentations are thyrotoxicosis, malignant change with a sudden increase in the size or sudden appearance of pressure symptoms. Bleeding into one of the follicles can lead to pain of very short duration and often self-limiting. Continuing the clinical features of multinodular goitre, hypothyroid is never seen in multinodular goitre. Hyperthyroid is likely to happen after 15 years due to a dominant toxic nodule. So predominantly they are euthyroid and occasionally you can get hyperthyroid status. Malignant risk is there though it is minuscule, and commonly papillary carcinoma thyroid is seen in biopsy specimen multinodular goitre. Coming to clinical features, family history of benign thyroid disease is often seen in patients with multinodular goitre. It is an insidious onset slow growing tumor in the anterior part of the neck. On examination, you may find single nodule or multinodularity. It increases in the size during pregnancy, obviously due to increased demand for thyroxine. Cosmetic complaints, asymmetry and tracheal deviation and or compression is a possibility. As I said, sudden pain or enlargement due to hemorrhage can be a clinical presentation. Hyperthyroidism with multinodular goitre, often called Brummer's disease, or autonomous nodule in the thyroid in the multinodular goitre. Rare features are superior vena cava compression, recurrent nerve palsy, recurrent laryngeal nerve palsy syndrome or Horner's syndrome.